Yeah, Guido's. A few of you who have done your interview with a pharmacist, boy, the 3, 4 I've gotten have been just outstanding. Hello? Hello? Oh, there. Can you hear me now?
Yes, you're good.
Okay, Audrey, we're dying to have an update on your pup.
Um, well, Thursday will mark 2 weeks being on the ventilator. But as of right now, he's receiving 75% oxygen. And so to move to the next step, which would be a tracheostomy, he has to be, his body needs to get stronger. He needs to be down to 50% oxygen before they can do the procedure. So,
Okay.
That's where we're at.
Okay, have you seen him?
I have not. My mom got to see him today and my older brother got to see him yesterday. So,
Okay,
but
and impressions or hard to say?
my brother felt comforted after he saw him and my mom came home crying. So, I don't know.
Okay, yeah, yeah. Okay. Well, he's still with us. That's something.
Yes,
How are you holding up?
I'm okay.
Just okay?
Just okay.
Okay is better than not okay. So, all right, let's go ahead. Could you guys hear that at all? You could? Okay. So Pop's still on the ventilator. He's at 75% oxygen. And they're trying to get that down so he can have a tracheostomy instead. Okay, let's have a word of prayer, then let's get started. Father, thank you for this cold, kind of windy day and for a cold day tomorrow. We continue to pray for Audrey's dad. Please strengthen him, help him to get better, help the raging inflammation in his body be quelled, and continue to lift him up to you for our dear friend Audrey. Please help her to get enough sleep and take care of herself and be able to do her schoolwork and also take care of her little sister and her mother. And thank you. Sounds like she has some help, and Lord, continue to support her. And now, Lord, support us as we talk about these GI drugs. There's quite a few of them, and we have a lot to do. In Jesus' name, amen. All right, gang. Let's go ahead and is that too glary? Can you see that all right? Little dark? Yeah. Yeah.
Beautiful. Oh, perfect.
Perfect. Can you see well enough to write?
Yeah.
Again, okay, don't fall asleep, okay? Morgan, I need you.
Got it. I got you, Dr. Reed. I'll hit her.
Good, okay. Yesterday was my birthday.
Happy birthday to you.
Cha cha cha.
Happy birthday to you.
Cha cha cha.
Happy birthday, Dr. Reed.
Cha 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 cha.
Happy birthday to you. Ariel 1. Ariel 2.
Yeah, so you guys will you'll reach the ripe old age of 60 someday. So and when you get there, you'll look back and say, what was all that about? All right, we talked about constipation. We will return to constipation when we talk about irritable bowel syndrome, because irritable bowel syndrome comes in, well, three main different forms: a constipation predominant form, a diarrhea predominant form, and then a kind of mixed form. So we'll talk about other drugs that are used mainly for irritable bowel syndrome and can address those concerns. Let's go now to drugs for kind of the other end of the spectrum, diarrhea. So the main problem, of course, with diarrhea is that the GI tract is not absorbing enough water, thus causing the stool to be very wet, and also there's increased motility. So you need to either increase absorption or decrease motility, because sometimes the bowel can be undergoing spasms. Those spasms are very painful, and viral infections will do this. So Norwalk viral infections, some GI type coronaviruses will cause those, some enteroviruses will cause such things, and everyone in this room's probably had one of those at least, and they're not very pleasant. So those, fortunately, we usually run their course, and unless the patient gets severely dehydrated, or the other issue with diarrhea usually is the loss of electrolytes. So you may get electrolyte abnormalities. And the bummer with this is if the medication causes that, but then again, some procedures can cause this too. So there's this condition called post-op nausea and vomiting. Anesthesia just makes some people really sick. They may be upchucking, or they may also have diarrhea. Then the so-called chemotherapy-induced nausea and vomiting. So the Emily, for example, her drug, her interview with the pharmacist was a chemotherapy drug, and that was all over her side effects. And that's one of the main reasons why when you treat people with these drugs, you have to give them time on, time off, because otherwise they won't be able to keep any fluids in or something like that. So one of your big jobs as a nurse is to really assess, well, dehydration, and then also just electrolytes. Because as you well know, electrolyte abnormalities can really cause trouble. They can cause cardiac issues, they can cause muscle weakness, they can cause nerve conduction issues. So electrolytes, and then knowing how to replace electrolytes is quite important. And then if someone's vomiting a lot, you're losing stomach acid. So that can actually cause alkalosis. So being able to address pH issues as well, that can often be a part of diarrhea and also vomiting as well. So these are things really to keep in mind. So what can you do for the, one thing to mention, antibiotics. Some antibiotics can be pretty hard on the gut, especially if you've never been on them before. So Tom Kunzelman upstairs, he had this awful pilonodular cyst, and he had to have it surgically extirpated. And then the doctor put him on metronidazole. And Tom was running to the loo every hour, it seemed. And he said, oh, this stuff is tearing my gut up. And he'd never been on it before. So antibiotics can do this. So one of the things you should do, first of all, is ask yourself, what's causing it? And if you know what's causing it, then you can try to address it. Now, the drugs that we will talk about should not be used in cases of bloody diarrhea, that's a bird of a different feather, or in cases of high fever, or some sort of systemic toxicity. Because if you use these drugs under these conditions, you might make these conditions work. So this would be contraindications, essentially, for all the drugs we're going to talk about. All right, questions before you dive in? Karis, was that a question or was that an itch? That was an itch, okay. Now, something you'll discover when you give your patients opioids, opioids tend to plug people up. They tend to cause constipation. So could you use opioids to quell diarrhea? Sure you could. And in fact, there are opioids that don't cross the blood-brain barrier. Because they don't cross the blood-brain barrier, they essentially don't cause the euphoria, at least, let me qualify that, at the dosages at which they're prescribed. They don't cause the euphoria, they don't cause that much respiratory depression, but they will deal with the GI issues, which is perfect for what you want. So these are peripherally acting opioids. But these are going to be ones that act peripherally. That's an age. All right, you may have heard of a product called Lomotil. And so it's low motility, low motil, kind of a cool name. This is a combination drug. So it is an opiate. This is called diphenoxylate. But it's coupled with atropine. You put those two together and you diminish propulsive peristalsis in the GI tract. So that's Lomotil. Another combo that's used is Modafen. This is another combination medication. Once again with atropine. And this one is called diphenoxin. So atropine is an anticholinergic. With anticholinergics, you're going to usually get higher heart rates. You'll usually also get some dry mouth. You may also get urinary retention. And you might also get increased intraocular pressures. In the elderly, you want to use anticholinergics with tremendous caution because they can cause confusion. And if the patient has dementia, they can make the dementia a lot worse. So in elderly, okay, I'm going to put a pair of eyes. That means watch for confusion and delirium. Got an elderly patient, they may get out of bed at night, wander around the ward. They may not know where they are. They may mistake you for a member of their family. What do you do if they call you by a name that's not yours? You go with it. No, Mrs. Taylor, I'm your nurse. I'm Allison. Come on, you know me. I introduced myself to you before you went to sleep. I'm Allison. That she's going to get mad. She's going to get more confused. And she's going to get harder to deal with. Just go with it. What are all these people doing in my house? Well, they're your friends. Just there to visit you. But you know, sweetheart, you need your sleep. Let's get you to sleep, okay? Just go with it. No harm, right? Then there is a product that's over the counter. You guys ever heard of Imodium? This was on the shelf, and then people were taking this at really high dosages to take the edge off their withdrawals. So I think you can still get this, but I think it might be behind the pharmacist counter. Has anyone been in a pharmacy recently and seen it on the shelf? Not that you were looking for it, but maybe you're looking for some ibuprofen or something and saw it. FDA actually pulled it in 2018 because of abuse. I think now they've reissued it. So this is loperamide. Yeah, but it's actually on the shelf. It's not,
Yeah, it's not.
it is, okay. All right, so these drugs are going to because they decrease motility in the bowel, you get more water reabsorption. So that's going to dry out the fecal mass. That'll decrease your diarrhea. They decrease GI motility. They do that by binding to opiate receptors in the GI tract. When you bind those receptors send an inhibitory message to smooth muscle. So let's now talk about that's in you. Now let's talk about the S part, the side effects. So they're opioids, so they can cause drowsiness. They can also cause people to be lightheaded. This, I'm gonna, you know what? This is age dependent. You use this in a young person? Not usually. Yeah, Shay?
Because this drug affects water reabsorption, does that mean if you took too much of it?
Can, yeah. With the dosing that you usually follow, it tends not to, but it can. It certainly can. Okay, and because if it has atropine, so the dry mouth, constipation with the atropine, so atropine can cause constipation, which is why it's in those medications. And then it can cause cotton mouth. Your mouth gets really dry because anticholinergics prevent secretion of saliva. Now, the potentially severe side effect is paralytic ileus. What's ileus? Remember that?
Isn't it like a complete blockage, like it's total?
Yeah, complete blockage in the ileum. So it can cause paralytic ileus with toxic megacolon. So these drugs tend to be contraindicated in people with an inflammatory bowel disease. This is most common in people with inflammatory bowel disease. Andrea, can you name me inflammatory bowel disease? Just inflammatory. It's some, yeah, they usually have bloody diarrhea, that sort of thing. Crohn, yeah. Crohn disease. What's the other one? Ulcerative colitis. That's one my wife has. And these, you don't want to use them because of this risk of toxic megacolon. So another CI, contraindication, inflammatory bowel diseases. Okay. Responsibilities of the nurse. So some of these are controlled substances. In particular, diphenoxylate. Because of that, you can get some dependence on this. Now, by combining it with atropine, I don't know if any of you have ever tasted atropine. Atropine tastes awful. So usually, if people take this with atropine, they have less of a tendency to get hooked on it because they put it in their mouth. It's just, ew, oh, ugh, ugh, no. But higher doses will have central nervous system effects. Prolonged use can cause opioid dependence. There. I should look up here more frequently. The other issue is if they become plugged up, then you back off the medication. Also with your patient, if it's an outpatient sort of thing, you need to encourage them to eat a healthy diet. Hydrate at least 2 to 3 liters water a day. Plenty of fruits and vegetables. Fiber, get your fiber. And that can usually help a ailing bowel as well. But the big issue with this is the addictive nature of this. Now, loperamide does not have any potential for addiction. So loperamide is not in that group. The diphenoxylate is. Yeah.
Does that mean if they stop taking it, they'll have withdrawal symptoms?
Yeah, in that case, yeah. But again, if the dose was really high, at the regular dose, usually there's not an issue. It's just patients, if they have a tendency, and this is another issue, is you might want to check if the doctor is going to prescribe that. You might want to check and see if they have a history of addiction. If they do, this might not be your best bet, because then they might want to take it and take a little more, take a lot more, take a little more. And you want to be looking for drug-seeking behaviors as well, that sort of thing. So, all right. Now, what if you have diarrhea because of excess fecal bile salts? Which causes diarrhea, which happens after gallbladder surgery or something like that. Then you can use the bile acid resins that we already talked about when we discussed cholesterol. So this includes things like cholestyramine and cholestyramine or cholesevolin. So these will bind up those excess bile acids, bile salts. They will be excreted in the fecal material, and these will tend to prevent, or at least stop, diarrhea due to excess fecal bile salts. Now, with these drugs, to remind you, we talked about this before, you do not administer them within 2 hours of other drugs. This drug here, cholesevolin, does not appear to have significant effects on the absorption of other drugs. These are not absorbed, so they don't cause systemic effects. All the effects, side effects they cause are GI related. So they can cause bloating. They can cause flatulence, gas. They can cause malabsorption of fat. That includes fat soluble vitamins. They can also cause constipation. So these should be taken with quite a bit of liquid. They usually come as powders. So you can just put them in some juice or something like that and bottoms up, and then chase it with quite a bit of water. If you drink quite a bit of water, that will tend to allay the constipation. Okay. We've already talked about these before, so I'm not going to talk about those much more. Okay. Now a compound I'm sure you've heard of. Heard of that before? Oh, you haven't? Oh, I'll bet you have heard of this. Now, have you heard of it? There you go. So this is going to, because it has this subsalicylate, this is going to decrease inflammation. So this is particularly good if you have diarrhea due to GI inflammation. That's what this is good for. It will also decrease motility due to prostaglandin production. So that's really when this is good. It's good to take this with you when you travel to a foreign land. If you might get on the wrong side of the drinking water, you might get the old saw, Montezuma's Revenge. And in that case, Pepto-Bismol can help you out a good deal. This stuff is pretty well tolerated. It tends to make your stools black, which can really freak people out. But if you warn them so they know what to expect, then it's not such a big deal. Also, it can darken the tongue. Some people say it causes nausea, but usually they already have nausea when they take it. So difficult to know if that's due to the Pepto. Another product that has this is over the counter and is called, that comedian on late night TV used to tell jokes about. Oh. Kaopectate. Kaopectate. That's the other product. That's bismuth subsalicylate. Okay. Your responsibility as a nurse and also education. This is only to be used for short periods. That subsalicylate, if you use that for too long, you'll get salicylate poisoning. And you want to avoid it in patients with renal insufficiency. Now that is available over the counter. It comes as a liquid, comes in little tablets, and it works quite well. Okay. Then there is a product you inject subcutaneously. It's called octreotide. So this is given SC. The trade name of this starts with an S. It's a sandostatin, that's it, sandostatin, which is a little confusing because it's not a statin. Sandostatin, and this also reduces intestinal secretion of fluid. And you get decreased motility. This is given usually TID, so every 8 hours. This drug, unfortunately, has a fair number of side effects. So the usual suspects, of course, nausea and abdominal pain. You kind of come to expect that in this group of drugs. And then flatulence. It will also sometimes, paradoxically, cause diarrhea. It can also increase your risk for getting gallstones. It can cause dizziness, cause headache. It can also mess with blood sugar. So it can either lower or raise blood sugar. And then it can also cause hypothyroidism. So that's a pretty respectable list of side effects. This tends to be used if you have diarrhea due to neuroendocrine tumors that secrete GI hormones that cause diarrhea. That's essentially what this drug is for. So your responsibility as a nurse, of course, is to watch blood sugar, signs of hypothyroidism, if the skin gets dry, if they get very cold all of a sudden, blood pressure might really start to drop. Hair loss, but if they're on chemo, they may be having hair loss anyway. The eyes might start to look sunken, these sorts of things. Getting a TSH is easy. That you could draw, send to the lab, they could measure that. If thyroid hormone production is low, TSH will be up. And then if that is the case, then you can draw and do a test for thyroid hormones themselves. All right. Okay, are there any questions on any of those medications before we look at inflammatory bowel disease? No? Okay. Zoom, any questions from anybody?
Nope, we're good.
You're good? Okay. Thank you, Audrey. All right, then we will go now to inflammatory bowel diseases. So there are two of these. There's, of course, Crohn's disease. And then there's ulcerative colitis. So, Crohn's disease. Crohn's disease can affect any part of the GI tract. Typically, the lesions are discontinuous. Sorry. Department of Biochemistry and Remedial Spelling. The lesions are discontinuous, but they're mural. Do you know what I mean when I say mural? That means they can go all the way through the lining of the GI tract. Therefore, these can cause fistulas. Fistulas. Ms. Jackson, can you tell me what a fistula is?
I don't know. I almost want to say like, I don't know.
Let's see, Sydney? Do you have any, do you have any idea?
Blood vessel.
You can have fistulas and blood vessels, yeah. What is a fistula, though, in general?
But like, don't they like put a fistula in like for blood flow?
They can. But what is a fistula? Emily?
Isn't it when it kind of connects two tissues that aren't supposed to be?
Yep.
connecting?
Yep. You have a hole. And that hole gives you a passageway to another cavity or something like that. So in women, the fistula and the rectum can actually cause fecal material to end up in the birth canal. That can cause some whopping vaginitises, as you might guess. And those need to be surgically repaired because they affect the entire, all the layers of the bowel. The mucosa, the submucosa, the muscularis, the serosa, and so on and so forth. Ulcerative colitis just affects the colon. These lesions tend to be continuous. And they only involve the mucosa. So a little pathophys review on IBDs. Both of these are due to autoimmune conditions. Crohn's disease is thought to be kind of a garden variety run-of-the-mill autoimmune disease. Turns out it's not. It's much more complicated than that. The latest theory is that your immune system is attacking your normal flora, and your bowel is an innocent bystander. That's the latest theory on what causes Crohn's disease. Ulcerative colitis, pretty clearly a common autoimmune disease. You have an immune response against antigens in the mucosal epithelia of the colon. You destroy it, it then starts to heal. Therefore, in both these diseases, you're at increased risk for colon cancer. So my wife has to have colonoscopies every year, now that she's reached that magic age. Okay. Yep, that's 60. Did you guys hear that so it used to be when you reach 50, you're supposed to have a colonoscopy. Now, the American College of Gastroenterologists has ratcheted that down to 45. Because colon cancers are rising for reasons that are not clear in younger people. So now they said 45, you need to start having colonoscopies. So, yeah, every 5 years after that, provided everything's fine, you don't have a condition that merits further watching. Okay. I'm not going to go over the histological differences between the two. Just suffice it to say, this picture, I think, is a nice little picture. So the thing you have in common with these two diseases, you have these symptoms of fever, abdominal pain, diarrhea, rectal bleeding, and weight loss. Fever, abdominal pain, diarrhea, rectal bleeding, and weight loss. I suppose so. So these 5 symptoms are common to both. They're a little bit nondescript, but essentially it's an IBD. Yeah, Shay? I'm sorry? Weight loss, yes. Loss of weight. All right. Smoking raises your risk of Crohn's disease, but smoking is actually protective when it comes to ulcerative colitis. Go figure. Smoking, yeah, don't ask me. It turns out some people with UC get symptom relief with nicotine patches. So nicotine's got something to do with it. No one has any clue what that is. Fascinating, huh? Here, smoke these boxes of cigarettes. Yeah, that would go over really well with the Board of Trustees. I'd be burned in effigy. So smoking is protective for UC, but it increases your risk of Crohn's disease. No, typically not. I'm not aware of a case of that. Okay, first set of drugs, as you might guess, are the corticosteroids. And this, of course, is going to include our old buddy prednisone or methyl prednisone or there's budesonide. And then, of course, hydrocortisone. These are meant to drive the disease into remission. They do a pretty good job of that. The thing is, once you get off them, sometimes you relapse. That's one of the downsides of these drugs. So these are systemic anti-inflammatory drugs. They're systemic anti-inflammatory drugs. They come mainly in oral forms. Budesonide in particular comes in a foam. So it's a rectal foam. They can also be given parenterally, usually intravenously.
How does that phone work?
I'm sorry?
How does that phone work?
Comes in an applicator that's about this big. And the foam is inside. You take the applicator off, you insert the applicator into your backside, and then it's a pump. You just go like that, and it jets the foam up through the rectum into the sigmoid colon. Then because of capillary pressure, capillary action, it'll actually go up to the splenic flexure. And because ulcerative colitis tends to be on the descending side of the colon, tends to start in the rectum, tends to then be restricted to the descending side. For ulcerative colitis, it works pretty well.
And this also for respiratory stuff?
Yeah, but you're obviously not going to use a rectal foam for
Yeah,
that.
I was just.
Yeah.
That's why I
Yes,
was confused
yes.
about it.
Budesonide is good for asthma. And in fact, the American Pulmonologist Society has just discovered in a study of asthmatics and COVID-19, asthmatics apparently on budesonide have a much lower risk of severe COVID-19. And so just as dexamethasone is being used to treat COVID-19 now, they're trying to use inhaled budesonide, and the initial study shows that it works. It can actually pull people out of severe disease, especially if they have acute respiratory distress syndrome. Okay, I have to stop getting off topic. We've talked about the side effects of these before. These are not meant for maintenance treatment. So not for maintenance treatment. They tend to cause weight gain. They tend to cause an increase in your blood lipids. Long-term, they can cause osteoporosis. They can cause hyperglycemia. We've talked about these before. Just these are for remission, not for maintenance. So you're going to use them short-term. The thing you want to make sure is that they're just used short-term. Well, then what do you use for maintenance? There's a group of drugs called the amino salicylates. And these are used as a maintenance treatment. The big drug in this group is mesalamine. This used to be marketed under the name Asacol, then it was Delzacol, and now it's just a generic. For which my wife is very happy because under license, this drug was so expensive. Now it's much cheaper. This is the main one. The other ones are Osalazine and Balsalazine. And then sulfasalazine. But this is definitely the main one. Now, here's the beauty of these drugs. These drugs are packaged in a tablet that goes through the GI tract, and as it gets to the GI tract, it gets dissolved. And then when it gets to the bowel where it's needed, it opens up and it coats the walls of the GI tract and suppresses inflammation. So it's not absorbed. So there's very few systemic side effects. Consequently, these drugs are very well tolerated. Very well tolerated. The reported side effects are things like nausea, vomiting, that almost always goes away. Headache. If you get a headache, switching between these tends to stop the headache. And then people with sulfa drug allergies will have allergies to sulfasalazine. Typically very well tolerated, these drugs. Those are your maintenance treatments, mesalamines. Very, very useful. All right. And the next group is the immunomodulators. And that is a good place to take a break and have some cake.
Get it. Have you ever put your cake with dental floss before?
Sorry?
Have you ever cut your cake with dental floss? Do you cut your cake with dental floss?
No, I haven't.
Yeah, you take floss, you like wrap it on your finger, and you'll take it with cake. That actually sounds like a really good idea. It's so good, it's so good.
Okay.
I'm not sure. Everything. What? Everything. I will lose. I'm sorry.
It's kind of a vanilla cake. It's actually good. Mental floss. I have to tell my daughter about that one. Oh, there's a cutting knife right here.
It's a good use of the floss that the dentist gives you.
Well, I bet your cuts are really clean. That sounds like something professionals would do.
I take my cake cutting very seriously. You chorus. You are not. She's gonna get that tattoo.
Yeah, I am. You're not. Yes, I am.
Where are you getting? Yes, you're in your hidden valley.
I'm supposed to get it when I did that exam. So I have to move my tattoo.
Oh my gosh. You were just telling me to put mental like earlier. Yeah,
I
okay.
texted her, I was like, hey, I have an exam, can we move it? So
awesome. That's not a lot of fun ever. It's always gonna be Hidden Valley. Dude, what happens when Hidden Valley no longer makes Hidden Valley? Then it'll be a throwback. Remember your dad? Like Campbell soup. That's the thing, shut up. That's tattooed. Oh, I know. I'm actually okay, thank you so much. And so staying cheap, Alabama. Oh, that's a joke.
Sydney, are you a big baker?
My mom says I can't bake, but I do.
What sort of things do you bake?
Well, at the Vice Heights house, we like this thing, it's called, cookie dough brownies.
Oh my goodness, that sounds good.
So it's brownies with egg with cookie dough on top. Big fan of no bakes and monster.
I'm just gonna put them here.
No, there you
for
go.
once and take them up.
Monster cookies. Thank you, Dr. Bates. My sister's a better baker though.
Really?
Yeah, all three of them.
Baking, it seems to me, takes a lot of patience.
My dad got more pigs this weekend. More pigs? Yeah. He went and met guys at truck stop. Picked up eggs. I don't know. Oh, dude, I don't even know if I'm doing that now. Really?
What are gonna be the new names soon? Yeah, I think there's some good jokes.
I don't know. Yeah.
My middle daughter watches all these videos. And she's, my mother taught cooking for a living. Mom had this ability to just, she could taste something and she could tell you what was in it. She was just very gifted in that regard.
Thank you. I love watching those cake decorating shows.
Well, some of those people are
Yeah,
so talented.
yeah, but it's like the cake doesn't look good though. Like it looks physically cool, but it doesn't look appetizing. Thank you. We'll get some cake over there.
You should eat it, it'll make it feel better.
The sugar.
I think
That's how it works,
it's
but
Dr. B
I
only
think
turned
that-
61. Go.
Dr. B, will you ever teach another class for us? Or is this the last class?
No, that's the last one.
You're gonna miss us.
I will,
That was a shock to the heart.
I will.
We'll come and visit stuff.
You guys are like daughters to me.
No sons.
That's how my dad feels too.
Do you really? Because you really. That's what I miss.
But who was the muffin today? Oh, Abby.
What?
Oh, yeah. She's 6 foot. Abby.
What was it?
My crippled mother.
I don't know why. Like Shakespeare.
I've seen a kid swallow hot dogs.
Ew. Tell me it's not true.
Oh, it's so true.
No good.
Did you never go to Cooperville High School and do your job? You didn't do that.
Thank you, Amanda Buck.
That was very good. How much is good? Good baker.
I certainly will.
Dude, this cake. You also tell me
No one's gonna get that. Please. I can grab it. I'll jump over my, what do you want? No, I'm waiting for everybody to get one.
Did everyone have cake?
Sydney. Yeah. Sydney just wants
Everyone
to.
have cake? Alice, want cake?
I don't know, it's looking.
Yeah.
Just do it, it's actually really.
I don't know. Dr. Beal, 261.
I'm really okay.
No, I really don't want it.
Sydney, I tried. Still, Emily, do you want a piece of cake? Yeah, I'm gonna okay.
No, I got one.
Okay. Anybody want a cake?
Anyone else want a cake before I eat it? Huh? No one else wanted this before I ate it?
I'll fight you for it. I'm just kidding.
I want to bite of it. You really? Yeah, I'm not done with my own. I'll come bring you this. Wait.
Okay. All right. Now, the immunomodulators come in a couple of shapes and sizes. So first of all, there are drugs that are metabolites that prevent the synthesis of nucleotides. Because immune cells, when they're activated, they divide. You have to make DNA. You prevent nucleotide synthesis. That tends to decrease inflammation and the immune response against your own tissues. So one of these drugs is called azathioprine. And a drug similar to it is mercaptopurine. Mercaptopurine. Both of these are meant for maintenance treatments of both ulcerative colitis and Crohn's disease. These usually will take about 3 to 6 months before you really see their full effect.
Within those 3 to 6 months, could you stick them on a corticosteroid or something else?
You can, and then wean them off the steroid. Yeah, you can. These drugs, again, because they suppress the synthesis of DNA, they have a few side effects that are not terribly desirable. So in the first place, they can cause myelosuppression. So as the nurse, what sort of things you need to keep your eye on? Can you be a bit more specific? Myelosuppression means they're suppressing the myeloid lineage of the bone marrow. So you're going to see decreased white blood cell counts, decreased red blood cell counts. So what do you use to assay? What do you use to determine if these are low? CBC, right. So the nurse's responsibility, she needs to do a complete blood count. That's going to be very important. Sorry? With, yeah, definitely with. Doesn't take that much longer to do with div. The other thing about these drugs is they can cause hepatotoxicity. So what are you going to do to check for this? Liver function test. There you go. Good. These drugs can also increase your risk of infection. So how do you tell your patient to lower their risk of infection? Hand hygiene. If they're in a crowded room, they feel like they're getting sick, they should wear a mask. wearing a mask in public now is a right bit more acceptable than it used to be.
Stick a patient on a drug in an isolated room.
Not if their immune system's on the fritz in the first place. If their immune system's fine, then sure. Sure. But if they have cancer or something else is going on, the immune system's a problem, then no, I'd wait until they get out of that side of the woods and then try to. Also, too, these drugs are meant for maintenance. So to push them into remittance, you're usually going to use steroids. So they increase your risk of infection. They can also cause nausea, vomiting, diarrhea. A rash is pretty common with them as too. Also, pulmonary edema. A more severe side effect is pancreatitis. And also hypersensitivity reactions. Have been reported. The use of these drugs long-term increases your risk of cancer. In particular, lymphoma. You see why you need to be watching that CBC? What other signs of lymphoma you can look for? Oh, pat yourself on the back. Enlarged lymph nodes. Now, which ones? Which ones usually develop first? Usually the neck. Usually the neck. So just a quick little feel, just like what your dentist does, usually is fine. But that's usually where you're going to get your first sentinel lymph nodes will be usually in the head neck area. These drugs should not be mixed with drugs that are given for gout, in particular allopurinol. So that's a contraindication. These drugs have to be activated in the liver by an enzyme that's inhibited by allopurinol. The use of thiopurine with an ACE inhibitor or with Bactrim can cause severe leukopenia. Severe leukopenia. So if you use an ACE inhibitor or Bactrim, what's Bactrim? Yep, that's your sulfa drug. You're at risk for severe leukopenia. Karis, what's leukopenia? Okay, penia. What is penia? If you say penia, the end of something, that means lack of. Lack of. Leukopenia, lack of white blood cells. Lack of white blood cells. Pat yourself on the back. Just not too hard. Might break your arm. Okay, one other drug that's used. That's an immunosuppressor is methotrexate. You will not. Now, we'll cover methotrexate when we talk about cancer drugs. Provided we get there, I'm so far behind. You won't use this at the same dose you would use for cancer. Having said that, this drug still has some side effects you really need to be aware of. So methotrexate also interferes with nucleic acid synthesis. But this is a good drug for maintaining remission, at least when it comes to Crohn's disease. This one is used mainly for Crohn's disease. It's not effective in ulcerative colitis. Let me rephrase. It's not been shown to be effective in ulcerative colitis. Okay, this one too also causes myelosuppression. This drug also causes alopecia. Or as the British say, alopecia. What's alopecia? Hair loss. Your hair falls out. Rash. Also very common with this drug, stomatitis. So you get sores around the mouth. Vomiting, that tends to go away. Diarrhea, that tends to go away. More severe side effects, GI hemorrhage. Hepatotoxicity. You can also have things like blurred vision. Hypotension. You can have a headache. Uric acid levels can go up. Now, it seems as though to decrease toxicity of methotrexate, if you tell the patient to supplement with folate, that seems to decrease the toxicity of methotrexate. So that's something you can advise your patient to do, supplement with folate. Folate. If you take methotrexate with NSAIDs, nonsteroidal anti-inflammatory drugs, aspirin, ibuprofen, drugs like that, you can raise the concentration of methotrexate and increase its toxicity. Same thing with proton pump inhibitors. That's methotrexate. Methotrexate has been found to be effective in Crohn's disease that does not respond to steroids. But you've got a lot of things to watch, essentially, with this drug. You're going to earn your salt with that one. Okay, finally, cyclosporin. This is a so-called calcineurin inhibitor. This has been shown to be effective for ulcerative colitis, not for Crohn's disease. Not for Crohn's disease. This drug also increases the risk of infection. It can also cause nausea, vomiting, diarrhea. The other thing this drug causes is hyperplasia of the gums. Gingival hyperplasia can also cause bad itching, pruritus, headache. There are reports that it can cause seizures. That is not common, but it's been reported. Also reports it can cause tremors. There's reports of that. It's not terribly common. It can cause visual disturbances. It can cause hypertension. It can also cause hepatotoxicity. It can be hard on the kidneys too, nephrotoxicity, hence its tendency to cause hypertension. You can also get some numbness with it, paresthesias. And then anaphylaxis to the drug has been reported too. If you combine this drug with other drugs known to be toxic to the kidney, you will potentiate the toxicity of the kidney. So if you give it with aminoglycosides or something like that, you'll increase damage to the kidney. If you give it with potassium-sparing diuretics, your chances for hyperkalemia go up. So you can give patients just regular eye tests to see essentially what's going on. Itching, there are lots of emollients you can recommend for patients. Women tend to use emollients anyway. Men tend not to. So if you tell them to use an emollient, they'll just say, gee, why didn't I think of that? Recommend some brands. Recommend the brand you use, something like that. For this, they may need to see their dentist if this becomes an issue. And so watch your blood pressure, watch your liver function tests, watch their urine output and their urine composition. Paresthesias, if they have numbness, tingling, that'll go away, but it can be very irritating. And then you may want to do a test batch, see if they're allergic to it. That's cyclosporin. Works for ulcerative colitis, not for Crohn's disease. All right. Biologics. First group of biologics, so these are usually monoclonal antibodies. They bind and inactivate certain elements of the immune system that signal to cells to execute inflammation. So the first of these are the tumor necrosis factor inhibitors. These are definitely first line if you go to a biologic. These bind to tumor necrosis factor alpha. They inactivate it. Tumor necrosis factor alpha is an important pro-inflammatory molecule. These inhibit that. These are very effective for both Crohn's disease and for ulcerative colitis. They tend to be used if the other things have failed. Some GI specialists are going to them more and more because their price is starting to come down and they work. They work. Okay, so the oldest of this group is this drug, infliximab. Notice they're going to end in MAB. MAB stands for monoclonal antibody. So if you see MAB at the end of a drug, it's a monoclonal antibody. This is the one that goes by the trade name of Remicade. Remicade. Then there's adalimumab. This is a drug I'm very sure you've heard of. Humira. Heard of Humira? That's Humira. Then there is the newer drug, golimumab. This goes by the trade name of Simponi. Simponi. Okay. These drugs are very useful at getting people off steroids. They're also good for your maintenance treatments. They come in injector pens. You teach the patient to inject, and the patient can self-inject. So they usually come in a pre-filled injector pen. So Humira is given, you start it every 2 weeks, then you take it every month. Infliximab, you take every 2 months. Golimumab, you take every month. Start with every 2 weeks and then for maintenance every month. For 2 months worth of treatment, infliximab is $4,500. Adalimumab for 2 months worth of treatment is $10,000. Golimumab for 2 months worth of treatment is $10,500. These drugs aren't cheap. They're not cheap. So usually, in order for the insurance to pay for them, the insurance needs evidence that you failed everything else. So usually, don't be thinking that you'll go to these first, even though the patient may find they work really well. Okay. Now, your job as a nurse, these increase your risk of reactivation of tuberculosis. So before they go on these, they need a TB test. The other thing that happens on these drugs is you can reactivate hepatitis B. So they need a hepatitis B test. And they should also probably get a Hep V vaccine if they haven't had one. If they have had one, maybe they should get a booster. That's a first order of business with these drugs. Secondly, you're at increased risk for TB, but also for invasive fungal infections. So they should stay away from organisms that are known to harbor certain fungi. For example, stay away from pigeons. Pigeon dung is loaded with Cryptococcus neoformans. Also, stay out of caves. Caves are full of bat guano. Bat guano is full of fungi that can infect you. And then hand hygiene, wearing a mask if needed. Don't be around people who are severely sick, what have you. Okay, the big side effect with these will be infusion reactions. Fusion reactions. There is no evidence of long-term risk of increased malignancy. There was thought to be. Larger studies have shown that doesn't seem to be the case. However, skin cancer risk does seem to increase. So what are you going to recommend your patient? Sunscreen and long sleeves and a broad-brimmed hat. So sun protection. Patients on TNF inhibitors should not receive vaccines. They will tend not to work. Other reports have included, yeah. Yeah, reactivation of hepatitis B has been reported. So if they have latent hepatitis B, you should get rid of the hepatitis B first before you go on these treatments. Yeah, so if they don't have latent hepatitis B, can you guys stay just a few more minutes? That'd be okay. Just so I can finish this up, and then next time we'll talk about the other ones. If they don't have hepatitis B, have they been vaccinated against hepatitis B? And if not, they should get vaccinated. If they have been vaccinated, maybe they should get a booster. It's been a really long time. Their infection maybe is why their, immunity has waned, then that might be something to consider. Because if they get hepatitis B, they're in deep weeds. They're gonna have to get off this drug, their disease is gonna come back, and then that's an issue. Okay, any more questions about TNF inhibitors? No? Okay, next time we will talk about Stelara. It's relatively new drug, Entyvio. And then we'll go to inflammatory bowel disease. Excuse me. irritable bowel disease. Then after that, we're going to get into reproductive drugs for the reproductive system. Right? Don't forget to do the quiz. It's due tonight before midnight. Okay, were you able to, excuse me. Were you not able to upload your, okay, gang, good night.
I have a question, Dr. B.
Oh, you have a question? Yeah, go ahead.
Yeah, I just wanted to double check, what was the asthma medication that you were talking about that you said?
Budesonide.
Okay. Can you spell that for me? I just want to maybe have my mom ask my dad's doctors about that. Boo.
See it?
Okay, yeah. And then you said that you had read like an article about it? Or no?
Yeah,
Okay.
it was actually
think I
on,
could just-
it was on Hippocrates.
Oh, it was.
So They
Okay.
made reference to it, so I can maybe possibly dig it up.
Okay. I have Hippocrates, so I could maybe look for it too.
Okay.
Okay. Awesome. Thank you.
Okay,
Bye.
bye.